guys want to just pass those out? Perfect, thank you. Okay, so my name's Jill Gerken. I'm a nurse here in interventional radiology. I actually used to teach with Erin at Clarkson College. So I'm doing this presentation on stroke for my master's degree. I'm going to have you guys go around the room and tell me your name and then where you think you might want to work after you graduate. So we'll start with you.
Rebecca, and then I like peds.
Okay, awesome.
Danica, I also like peds or OB. I mean, we haven't been through a semester, but
Yeah,
I think.
awesome.
Natasha and hospice.
Oh, cool.
I'm Lexi and I want to work in neuro ICU.
Excellent.
I'm Candy and OB.
OB.
Preston, not sure yet.
Okay.
Jared and ER.
ER.
Sydney and OB.
Sydney and OB. Awesome. Well, so my background is critical care. I worked in the cardiac ICU for a while. And then I became a clinical educator here at Nebraska Medicine, where I was Danica's educator. And then decided that I wanted to go back to patient care, so I went into interventional radiology, where we actually get to deal with some of the strokes. We're kind of they come to us, we fix them, and then we ship them up to Lexi. So I'm just gonna go over strokes with you guys, kind of teach you guys a little bit of things. You might find some things that you didn't know before. If you guys have questions, I want this to be super interactive, so there's a couple questions throughout my presentation. So if you guys know the answer, just raise your hand, okay? Oh, shoot, okay. Okay, so first thing, we'll go over some of the objectives that I want you guys to know when this presentation's over. I want you to define the different types of strokes. We're gonna have you describe the signs and symptoms of strokes, break down key assessments that you as the nurse would complete on a patient, even if they're not having a stroke, but how you would find out if they potentially are. Determine the best treatment options for the different types of strokes. And then plan priority care on potential stroke patient. All right. And then some of the terms that are used a lot of times with strokes are aphasia, so inability to use or comprehend language. So those are the patients that you have to talk to, or you'll go on their opposite side of where they had their stroke, talk to them. Lots of patience is needed with these patients. A lot of yes/no questions, things like that. Alexia is difficulty reading, so depending on what part of the brain the stroke affected, they may have difficulty reading. Agraphia is difficulty writing, so depending, again, where the stroke happened in the brain, they may have difficulty writing, but they may be able to read and articulate things fine. And then lastly, dysphagia is difficulty swallowing. So this happens with almost all stroke patients. That's why we have a speech pathologist come and do swallow studies. Also, the nurses here at Nebraska Medicine are trained to do swallow studies. So have you guys had a chance to see or complete a swallow study? Have you? Anybody? Yes? Excellent. You'll notice sometimes too that those patients will need like thickened liquids or be on a soft or pureed diet. All right, so what is a stroke? So the correct term for a stroke is a cerebral vascular accident, so CVA. They're also known as a brain attack. So just kind of a name that the National Stroke Association calls it by is a brain attack. But essentially it's the lack of blood supply to the vein. Either a clot is in the way or there's bleeding in the brain. Anytime a patient is having a stroke, it is a medical emergency. So if you're not in the hospital setting, call 911. We're going to get them to the hospital as soon as possible. If you are in the hospital, there's numbers that you would call to alert the stroke team, and then a bunch of doctors, nurses, respiratory would come down and actually see the patient and get them to where they need to be. All right, so some statistics. Stroke is the 5th leading cause of death in the United States. Every 4 minutes, someone dies from a stroke. Annually, 800,000 people are experiencing strokes. Every 40 seconds, a stroke happens, and it is the leading cause of disability in the United States, which is kind of frustrating because 80% of strokes can be prevented. I just kind of put these on there just to reiterate the seriousness of strokes. They definitely are life-changing. I had an aunt that had a stroke a couple years ago, and she's no longer can work, she can't drive, has seizures all the time, so it's very debilitating to say the least. All right, so the different types of strokes are ischemic, hemorrhagic, and transient ischemic attacks, so a TIA. The ischemic strokes have two different kinds, a thrombolytic and an embolic. Hemorrhagic strokes are intracranial hemorrhages or subarachnoid hemorrhages. And we'll go over those more in depth. So, an ischemic stroke is the most common type of stroke. This happens in 85% of patients who have a stroke. It's caused by an occlusion, so either an occlusion in an artery in the brain, or a dislodged clot. So a thrombolytic stroke is a clot that's in the brain. An embolic stroke is a dislodged clot. So that happens when someone who may have atrial fibrillation, has some clots in their heart, starts going up your carotid arteries, gets dislodged when there's plaque in your arteries. And hemorrhagic stroke, so this is when a blood vessel breaks in the brain. This can also happen if someone falls and is on blood thinners, your brain starts bleeding. So I always just think of hemorrhagic strokes as brain bleeds, okay? They're less common, but they do cause 40% of the deaths that happen in strokes. An intracerebral stroke or hemorrhagic stroke is something that happens more inside the brain. So this is caused more of with aging, vessels start to get weakened. Also hypertension would cause an intracerebral hemorrhage. Subarachnoid is more of those brain bleeds, so you fall, hit your head. It's on the outer side where the dura is. What else? AVMs can also cause subdural hemorrhages. And then a transient ischemic attack, so that TIA, these are the mini strokes, and these are very serious, not as serious as an actual stroke, but they still are serious in the fact that it's a mini stroke. These are patients that are starting to have symptoms, and there's a potential that they could have a stroke. They're at the highest risk for a stroke in the first 24 hours after they have these stroke-like symptoms. So it's still considered a medical emergency. They still need to come into the ER, 911. If you have a patient that's having these signs and symptoms, again, you're gonna call the stroke team and have them evaluated. Usually the symptoms last less than 24 hours, but again, after that 24-hour mark, they have a higher risk for developing a stroke. All right, so causes of stroke, hypertension. So the amount of blood that keeps pumping through your body at a higher level kind of weakens those blood vessels, can cause a stroke. Atrial fibrillation, I kind of talked about developing clots in your heart that kind of move upward towards your brain. Heart disease, smoking. Smoking and high cholesterol, I think of, that's that plaque buildup in your veins or your arteries. Alcohol use, poor diet, and obesity. So here's a little picture of the brain. So I just kind of wanted to point out the different places in the brain and what they control in your body. So basically the frontal lobe is your thinking, your personality. So this can be, if a patient has a frontal lobe stroke, their emotions are going to be different. They are not going to be able to think properly or articulate what they're thinking. Your left side of your brain is your memory and your understanding. So again, they're not going to understand what's going on. They may be saying funny words, things like that. We'll go on. All right, so some signs and symptoms of a stroke. Weakness in your extremities. So this is usually one side of your body. You guys know how the brain works. Okay, sorry guys. your left side of your brain controls your right side controls your left side. So you're gonna notice weakness in one side of the body. So you may have numbness or tingling in your left hand. Your patient may not be able to squeeze as tight on your right hand or your left hand. Sudden loss of vision, especially in one eye, again, the left, right. Difficulty speaking, inability to understand what people are saying, dizziness or loss of balance, seizures, and excruciating headaches. So those excruciating headaches are more of that subarachnoid hemorrhage, and those are the very, very serious ones. So think of the acronym FAST. Do any of you guys know what that stands for? Anybody? Can anybody guess what it stands for? F.
Face drooping, something this time.
Facial drooping. Yep.
Speech.
So exactly. Very good. All right. So this is a brain buster, guys. Okay. You're shopping at Target and you think someone may be having a stroke. What signs and symptoms might you see in this person to make you believe it is a stroke? So what are you going to see in this patient? Weakness. Trouble speaking, good. Drooping face, good. And then what would you do for this person? Good. Stay with them. See if they have family. So this scenario was actually my aunt. My grandma and my aunt were shopping in Target. My aunt went to go to the bathroom. 30 minutes later, my grandma couldn't find her. She came out of the bathroom. She had been walking kind of towards one part of the aisle, kept running into the aisle. Peed her pants, facial droop, couldn't talk, couldn't articulate anything. Thank God there were 2 nurses that came and helped her out, called 911, got her to the hospital. So, just fun fact. Good, you guys already got the FAST acronym. So, F for facial drooping, A, arm weakness, S, speech difficulty, and T is time. And this is a big community outreach right now. We are trying to teach this to just the public in general because the faster we get these patients into the hospital to be seen, the better the outcomes they have. So again, just trying to teach everyone about the FAST acronym for strokes. All right, so you have a set of vitals, and I'm not going to read them out for you guys, but if you guys want to look, and then what set of vitals would you call the doctor about? What would alert you mostly if you had a patient who had a stroke and you're watching them? And why? Anyone have a guess?
Would it be the second one?
Yep, it's E. Why?
Report touching?
Yep. So usually when you, gosh, this darn thing. Usually when you have a patient who has had a stroke, you're gonna keep a really close eye on their blood pressure. When they're in the ICU, it's usually less than 140 systolically. I don't know why this is not staying on. When they get to the floor, they're usually okay with anything below 160. So 169 over 100 is elevated blood pressure. You're gonna watch that for sure. All right, so how do you diagnose someone with a stroke? So signs and symptoms are your first key. If you notice that your patient is having signs or symptoms of a stroke, you're gonna wanna get them looked at. The next thing that usually happens is a CT scan. So they're gonna take them down into the CT scan. They're gonna see, A, is the patient bleeding in their brain? If they're not bleeding, do they have a clot? Is there some sort of blockage in their artery that's not letting blood perfuse to the rest of the brain? MRI is usually something that they would do after. If they can't figure out what's going on in the CT, they may do an MRI scan. And then ultrasound, cardiovascular sonography is something that we use here at Breast Medicine. They would Doppler the carotids and see if they can find a blockage in the carotid. So, why would you get a 12-lead EKG? Yep, you're going to want to see if your patient's having any arrhythmias or if they have atrial fibrillation to kind of lead you to maybe they threw a clot. All right, so interventions. You're gonna determine the type and extent of the strokes. We just talked about that. That patient, so we'll just do a patient scenario. Patient's coming from Bellevue, they think they had a stroke. The ER is gonna be alerted. They're gonna come through that door and they're gonna get straight to the CT scanner, okay? Barely get 2 IVs in them, maybe do a little neuro assessment, but they're going straight to the CT scanner. You're gonna always place 2 IVs on these patients in case they do either need to go to surgery or if they need to go to interventional radiology for interventions. So if they go to interventional radiology, it usually means that they are having a thrombolytic stroke, so there's a clot. And what we do is we will go in and place a catheter in their groin. We fish up a wire and they try to find that clot. And they either suck it out or they will bust it with TPA. When they suck that clot out, they will give them a TICI score, which is basically how well they're reperfusing. So a TICI score of 3 is the best. Usually we get anywhere from a 2 to a 3. Again, this is all about timeliness. So if the patient's been having these symptoms for 8 hours, we may not be able to do anything about it. So these patients will go to Lexi in the neuro ICU at least 24 to 48 hours, if not longer. They will complete neuro assessments every hour and monitor ICPs if necessary. All right, so what does FAST stand for? We're gonna do this again. Yep. Perfect. Okay. And how would you assess this patient if they were actually having a stroke? Do the same thing. Neuro assessment. Yep. Good job. All right. So treatment for an ischemic stroke, you're going to do fibrolytic therapy. So if this patient is less than 80 years old, they don't have a history of a fall in the last couple weeks, they're not on blood thinners, they're going to take them to the CT scanner. If they see a stroke, they will start TPA. Otherwise, endovascular interventions, that's when they would come to me in IR, and then monitor for increased ICPs when they go to the neuro ICU. Hemorrhagic stroke, basically we're going to control the blood pressure. Those are the patients that come in with blood pressures of 200 over 100. We want to watch them super closely, make sure that that's not, that bleed does not get any worse. Again, you're going to do the ICP monitoring, so intro, I can talk, okay. They'll put a ventric drain in to help drain that fluid around their brain and keep those ICPs low. And then also surgical treatment. So sometimes they will take them back a week after and do craniotomy and things like that to evacuate those clots. All right, so LH is a 54-year-old female. She was found down at the grocery store at 12:54. The patient was found to have slurred speech, facial droop, was unable to walk, and was incontinent of urine. What are 5 priority interventions that you would do that the nurse would complete upon entering the ER? So I kind of went over this before.
Time.
What?
Time.
Okay.
Well, it's there.
12 lead EKG.
IVs.
IVs, 2 IVs. CT. Get them to where they need to go if necessary. Talk with family. Stay calm for the patient's sake. They can't articulate what's going on. They're scared, so explain things to them, okay? All right, so medications that you may see with these patients, tissue plasminogen activator, so the TPA, that's that clot buster. These patients may get this in ER. If it's a stroke that they can't get to in interventional radiology, they may just try the TPA. Coumadin, a lot of these patients will get put on Coumadin if they do have AFib, not until obviously after the stroke is, safe. But Keppra, what's Keppra? Medication for seizures. So almost all of these patients, unless contraindicated, will get put on some sort of seizure medication. Keppra is the most common one we use here at Nebraska Medicine. And then aspirin and Plavix. All these patients that come in for a clot stroke will get put on these. Okay. So prevention, non-modifiable risk factors. So age, sex, race, family history are all things that we obviously can't change. Race, strokes happen more in men. Family history, if your mom or your brother or your grandpa had a stroke, you're at higher risk for stroke. Let's see here, race, African Americans, American Indians, and Alaskans tend to have higher risk for stroke, and then anyone above the age of 60. So some modifiable risk factors: diet, exercise, limit smoking or quit smoking, and then moderate alcohol intake. And then one thing that you guys should know is metabolic syndrome. So this is when you have 3 out of the 4 of these: weight that's predominantly in your midsection, high blood pressure, high blood sugar, so diabetes, or unhealthy cholesterol levels. If you have 3 out of the 4 of these, your stroke risks increase a ton. Also, if you have polycystic ovarian syndrome, you're at a higher risk for stroke. I learned that while making this presentation. All right, so nursing assessment, you guys are doing these a lot on this floor. Importance of a head-to-toe assessment. So why is it important to do these head-to-toe assessments, even on a patient who hasn't had a stroke?
To notice changes early.
Yep, exactly. You want to make sure, A, you know your patient well, but then the next time you go in there, if something's off, you want to know when their time last well was, so that when you do call the team, you can say, hey, you know what, I went in there at 10 a.m., did my first assessment. She answered all my questions appropriately. She was strong throughout her body. Her pupils were round, reacting to light. Now she's got one pupil that's a 5, one pupil that's a 2, not reacting to light. She's got slurred speech. All things that you want to be able to assess and be confident with when you do talk to the doctor. Let's see here. Last time known well, we talked about that, the importance of that. Time is of the essence. Have you guys had a chance to do the complex neuro assessment on this floor? No? Did they not let you do them, or no?
I've seen it done several times.
So what are some things that they do with a complex neuro?
Put your arms out, touching that one.
Yep. Push against me. Can you feel me touching? Yep, exactly. So anytime a patient has a stroke, they will do those because they want to know if it's getting worse or if it's getting better. All right, so some nursing diagnoses for these patients would be inadequate perfusion to the brain, impaired swelling, impaired physical mobility. What are some others that you guys can think of? You probably had to do concept maps or care plans with these.
They don't do nursing diagnoses anymore.
Oh, we don't do that anymore. Okay, never mind. Well, here's some. All right, and then the healthcare team as a whole is super important with these patients. You're going to see neurosurgeon doctors. You're going to see neurology, nurses, you the nurse taking care of the patient, physical therapists, occupational therapists, speech pathologists, dietitians, and then rehab. So the main focus on these after they go home is rehabilitation. A lot of times they go to rehab centers to get their strength back, work on their diet, eating, basic things, going to the grocery store, paying money. My aunt was in Madonna for, I want to say, 2 to 3 weeks, and she still has a hard time counting money. So when she goes to the grocery store, she can't count the right change. It's odd, but the brain is a funny thing, you guys. Okay, pop quiz. You are teaching your patient about stroke prevention. Which one of the following statements from your patient would you need further teaching? Anybody? Danica? I'm picking on you.
Sorry.
You're okay. Or Lexi?
Is it B?
It's B. Sinus bradycardia is usually not a bad thing to have because it's usually all those nice petite runners that have heart rates in the 50s all the time. They're at a lesser risk of having a stroke. All right, so you are the nurse taking care of a new admit on the cardiac med-surg unit. when completing your initial head-to-toe assessment, you are concerned that your patient may be having a stroke. What are some signs and symptoms that lead to this conclusion? So we're gonna select all that apply, doing these NCLEX questionnaires, you guys. B and D, good job. All right, references. Do you guys have any questions? All right, so let's go over these objectives again. What are the 3 types of strokes that we went over? Preston? Ischemic, hemorrhagic, excellent. Let's see here, some signs and symptoms. You guys kind of went over that with the FAST. Let's see here. What's priority care if you're noticing your patient has a stroke? What? CT, good. 2 IVs. All right. Any questions, you guys?
I do have one.
Okay.
After you have 1 stroke, what is like, okay, so my patient today had 2 TIAs last week.
Okay.
Had a stroke on Saturday here in the hospital.
Perfect
He
example
noticed-
of what we just covered.
Yeah, and then like today he had like a hot flash, dizziness, you know, just having some little like things that they're
Okay.
like monitoring. What's the like thing
So-
you're most looking for to like
So any of those signs and symptoms, so are they doing the neuro, the complex neuros on your patient? So they're gonna, anything that's off, that's an alert. They may do another CT scan just to see if there's any changes, if there is any ischemia in the brain, but if he had 2 TIAs last week and then he actually did have a stroke, they're just gonna be watching him super closely.
so what could he have another one?
Absolutely.
You can just have like several
Yep. Yeah, just, I mean, depending, did he have a clot and that caused a stroke, or?
Yeah, I read up on it. I don't know all the details, 'cause
Sure.
I started with 1 patient and then like I didn't pre-lab on him,
Sure.
but
My guess would be.
he had like the left side weakness and all that. So.
Yeah, so probably a thrombolytic stroke. Yeah, if he was having TIAs multiple times and then developed a stroke, I'm just thinking without seeing the patient or knowing them, I'm thinking there's probably clots and they're watching that to see if he's gonna have any more clots go up to his brain. Hi, Erin.
Could you talk to them about stroke accreditation for a hospital?
Sure. So Nebraska Medicine is a stroke accredited hospital. So anytime or any nurse that takes care of a patient who has a stroke, so the ER, interventional radiology, 6 neuro, neuro ICU, those nurses have to get an additional 8 credit hours of stroke hours. So we either have to do CEUs that go along with stroke, there's classes and things like that offered. Also, we have to have a call team, so I'm part of the call team for stroke. If they come into the ER, they come straight up to IR. I have to be here within 30 minutes to come and help with the stroke. We have 2 or 3 neurosurgeons. One is always on call for a stroke, and then there's always one that has to stay in town for a stroke. So another thing is time is of the essence. We have to have that patient on the table within a certain amount of time, things like that. So, yeah. Any other questions? Okay, awesome. Well, thank you guys so much. I really appreciate it.